Welcome to Pediatric Case Review. Today's lecture is a comprehensive case-based review of juvenile idiopathic arthritis, designed for general pediatric physicians. We will work through 15 carefully selected clinical cases covering all major subtypes, pathophysiology, immune mechanisms, evidence-based diagnostic approaches, current treatment algorithms including biologics, and critical complications such as uveitis and macrophage activation syndrome. This lecture was prepared in March 2026 and reflects current clinical guidelines. Let us begin. Case 1. A 4-year-old girl presents with a 7-week history of limping and morning stiffness in her right knee. Her parents report that she walks better after moving around, but has difficulty getting out of bed each morning. Physical examination reveals moderate swelling of the right knee with warmth, but no erythema. She denies fever, rash, or recent trauma. Her appetite is normal, and she appears well otherwise. What is the most likely diagnosis? Option A, septic arthritis. Option B, toxic synovitis. Option C, oligoarticular juvenile idiopathic arthritis. Option D, Legg-Calvé-Perthes disease. The correct answer is option C, oligoarticular juvenile idiopathic arthritis. This case demonstrates the classic triad of this subtype: persistent joint swelling lasting 6 weeks or more, morning stiffness lasting more than 30 minutes that improves with activity, and absence of systemic symptoms such as fever or rash. Septic arthritis would present with fever and acute onset requiring urgent surgical drainage. Toxic synovitis usually follows a viral illness and resolves quickly, typically within 2 weeks. Legg-Calvé-Perthes disease typically affects boys aged 4 to 8 years with no morning stiffness and has characteristic changes on imaging. The magnetic resonance imaging shown confirms synovial thickening and bone marrow edema consistent with oligoarticular juvenile idiopathic arthritis. Case 2. A 6-year-old boy presents with a 2-week history of daily spiking fevers reaching 39 degrees Celsius, equivalent to 102.2 degrees Fahrenheit. His parents report a transient salmon-colored rash that appears during fever episodes and disappears when the fever subsides. Physical examination reveals generalized lymphadenopathy, hepatosplenomegaly, and bilateral knee swelling with warmth. Laboratory results show elevated C-reactive protein at 85 milligrams per liter, erythrocyte sedimentation rate at 95 millimeters per hour, and markedly elevated ferritin at 1,200 nanograms per milliliter. Complete blood count shows leukocytosis with neutrophilia. What is the most likely diagnosis? Option A, Kawasaki disease. Option B, acute lymphoblastic leukemia. Option C, systemic onset juvenile idiopathic arthritis. Option D, infectious mononucleosis. The correct answer is option C, systemic onset juvenile idiopathic arthritis. Note, the answer banner shows option B, but the label text confirms systemic onset juvenile idiopathic arthritis, which is option C on the question slide. Please verify before publishing. Diagnostic criteria include daily spiking fever of 39 degrees Celsius or above for at least 2 weeks documented on at least 3 days, the characteristic salmon-colored evanescent rash, hepatosplenomegaly, generalized lymphadenopathy, and serositis including pericarditis, pleuritis, or peritonitis. Arthritis may be absent initially and develop later. Key laboratory findings include markedly elevated ferritin above 500 micrograms per liter, often above 1,000, high erythrocyte sedimentation rate and C-reactive protein, leukocytosis with neutrophilia, and thrombocytosis in active disease. Important alert: ferritin above 2,000 micrograms per liter may indicate macrophage activation syndrome, a life-threatening complication requiring immediate intervention. Case 3. A 12-year-old boy presents with a 3-month history of lower back pain and right hip discomfort. His symptoms are worse in the morning and improve with activity. He denies fever, rash, or family history of arthritis. Physical examination reveals a positive sacroiliac compression test, limited lumbar spine flexion with fingertips to floor at 25 centimeters, reduced internal rotation of the right hip, tenderness over the Achilles tendon insertion, and no peripheral joint swelling. What is the most likely juvenile idiopathic arthritis subtype? Option A, oligoarticular juvenile idiopathic arthritis. Option B, polyarticular juvenile idiopathic arthritis. Option C, systemic onset juvenile idiopathic arthritis. Option D, enthesitis-related arthritis. The correct answer is option D, enthesitis-related arthritis. Key diagnostic features include male predominance with a 6-to-1 ratio, onset typically after age 6 years, asymmetric lower limb arthritis, enthesitis at the heel, knee, and hip insertions, and family history of spondyloarthropathy. Human leukocyte antigen B27 positivity in adolescent males with lower back pain and hip involvement strongly suggests this diagnosis. This genetic marker is present in 80 to 90% of cases and indicates higher risk for axial involvement and progression to ankylosing spondylitis. The Schober test measures lumbar spine flexion. Normal expansion is greater than 5 centimeters, indicating good spinal mobility. Reduced expansion suggests sacroiliitis or spinal inflammation typical of this subtype. Pelvic X-ray may show bilateral sacroiliac joint sclerosis, joint space narrowing, and subchondral erosions, but magnetic resonance imaging is more sensitive for detecting early bone marrow edema. Case 4. A 9-year-old girl presents with a 3-month history of swollen fingers affecting her right index and middle fingers. Her mother reports that the entire fingers appear sausage-like. On examination, you notice small pits in several fingernails and toenails. She has no fever or systemic symptoms. Her father has a history of psoriasis. Joint examination reveals asymmetric arthritis affecting 3 joints in total. What is the most likely juvenile idiopathic arthritis subtype? Option A, oligoarticular juvenile idiopathic arthritis. Option B, polyarticular juvenile idiopathic arthritis, rheumatoid factor negative. Option C, juvenile psoriatic arthritis. Option D, enthesitis-related arthritis. The correct answer is option C, juvenile psoriatic arthritis. Note, the answer banner shows option D, but the explanation text clearly describes juvenile psoriatic arthritis as the answer. Please verify the answer key before publishing. Juvenile psoriatic arthritis is characterized by the classic triad of dactylitis, which is uniform sausage-like swelling of an entire digit, nail changes including nail pitting and onycholysis, and asymmetric joint involvement. The combination of swollen fingers with nail pitting strongly suggests this diagnosis over other juvenile idiopathic arthritis subtypes. Diagnostic hallmarks include dactylitis with uniform swelling of the entire digit, nail pitting and onycholysis, asymmetric arthritis pattern, family history of psoriasis, which is present in approximately 40% of cases, and absence of rheumatoid factor. Case 5. A 6-year-old girl with oligoarticular juvenile idiopathic arthritis shows persistent knee swelling despite initial nonsteroidal anti-inflammatory drug therapy. Synovial biopsy reveals dense lymphocytic infiltration with characteristic cytokine expression patterns. Research studies demonstrate specific T helper cell subset activation driving the inflammatory cascade in her joint tissue. Which cytokine pathway is primarily responsible for driving synovial inflammation in nonsystemic juvenile idiopathic arthritis subtypes? Option A, interleukin-1 beta and tumor necrosis factor alpha inflammatory cascade. Option B, interleukin-17 and interleukin-23 T helper 17 pathway activation. Option C, interferon gamma and interleukin-12 T helper 1 cell responses. Option D, interleukin-4 and interleukin-13 T helper 2 allergic pathways. The correct answer is option A, interleukin-1 beta and tumor necrosis factor alpha inflammatory cascade. The pathogenesis of oligoarticular and polyarticular juvenile idiopathic arthritis is primarily driven by established inflammatory cytokine cascades involving tumor necrosis factor alpha and interleukin-6. These cytokines promote synovial hyperplasia, osteoclast activation, and cartilage degradation. T helper 1 response is mediated by interferon gamma, also maintain chronic synovial inflammation. The T helper 17 and interleukin 23 axis, while contributing, is a more prominent feature of other subtypes like enthesitis-related arthritis and psoriatic juvenile idiopathic arthritis. 3 key mechanisms. Tumor necrosis factor alpha drives synovial hyperplasia and osteoclast activation. Interleukin-6 promotes the acute phase response and bone resorption, and T helper 1 interferon gamma responses maintain chronic synovial inflammation. Case 6. A 7-year-old boy presents with daily spiking fevers reaching 39 degrees Celsius, accompanied by a transient salmon-colored rash that appears during fever peaks. His parents report generalized lymphadenopathy and recent onset of bilateral knee pain. Physical examination reveals hepatosplenomegaly. Laboratory investigations show markedly elevated C-reactive protein at 85 mg per liter, ferritin at 1,200 nanograms per milliliter, and erythrocyte sedimentation rate at 95 millimeters per hour. What distinguishes the immunopathological mechanism of systemic juvenile idiopathic arthritis from other subtypes? Option A, predominant autoantibody production and B-cell activation. Option B, T helper 17 cell dysregulation and adaptive immunity. Option C, overactivation of the innate immune system and inflammasome pathways. Option D, complement cascade dysfunction and immune complex formation. The correct answer is option C, overactivation of the innate immune system and inflammasome pathways. Systemic juvenile idiopathic arthritis is fundamentally an autoinflammatory disorder, not autoimmune. It involves uncontrolled activation of the innate immune system, particularly monocytes and macrophages, leading to excessive cytokine release. The NLRP3 inflammasome pathway is central. NLRP3 activation leads to caspase-1 cleavage, which converts pro-interleukin-1 beta into mature interleukin-1 beta, triggering a systemic inflammation cascade causing fever, rash, and organ dysfunction. High ferritin above 500 micrograms per liter indicates macrophage activation and risk of macrophage activation syndrome. This autoinflammatory mechanism is why interleukin-1 blockade with anakinra and interleukin-6 blockade with tocilizumab are specifically effective in systemic juvenile idiopathic arthritis, unlike tumor necrosis factor inhibitors, which are less effective. Case 7. A 9-year-old boy presents with joint pain and swelling. His mother reports intermittent knee and ankle swelling for the past 4 weeks, with some improvement during weekends. He experienced a similar episode 2 months ago that resolved completely after 3 weeks. Physical examination shows mild swelling of the right knee with limited range of motion. No fever, rash, or other systemic symptoms are present. According to International League of Associations for Rheumatology classification criteria, what is required to diagnose juvenile idiopathic arthritis in this patient? Option A, arthritis in at least 2 joints for a minimum of 4 weeks. Option B, persistent arthritis in 1 or more joints for at least 6 weeks. Option C, joint swelling with fever for a minimum of 2 weeks. Option D, positive inflammatory markers with joint symptoms for 4 weeks. The correct answer is option B, persistent arthritis in 1 or more joints for at least 6 weeks. The cornerstone of juvenile idiopathic arthritis diagnosis is persistent arthritis lasting more than 6 weeks in 1 or more joints. This duration criterion distinguishes chronic inflammatory arthritis from transient reactive conditions. Key points. Duration greater than 6 weeks equals chronic inflammation. It is a clinical diagnosis with no single confirmatory test. Infection, malignancy, and trauma must be excluded, and laboratory markers support but do not make the diagnosis. Important reminder, juvenile idiopathic arthritis is a diagnosis of exclusion. The timeline matters. Weeks 1 and 2 suggest an acute phase where infection should be considered. Weeks 3 and 4 are subacute requiring close monitoring, and week 6 or beyond meets the criteria for chronic juvenile idiopathic arthritis. Case 8. A 10-year-old boy presents with a 3-month history of persistent right hip pain and subtle limping. He denies fever or trauma. Physical examination reveals limited internal rotation of the right hip with mild tenderness over the greater trochanter. Plain radiographs of the pelvis appear normal with no evidence of joint space narrowing or bone abnormalities. Which imaging modality is most sensitive for detecting early synovitis and bone marrow changes in this patient? Option A, plain radiography with additional views. Option B, computed tomography scan. Option C, magnetic resonance imaging. Option D, bone scintigraphy. The correct answer is option C, magnetic resonance imaging. Magnetic resonance imaging is the gold standard for detecting early synovitis, bone marrow edema, and cartilage damage in juvenile idiopathic arthritis. These changes are often invisible on plain radiographs or ultrasound. Why magnetic resonance imaging is superior? It visualizes bone marrow edema before structural damage occurs, detects synovial thickening and enhancement, assesses cartilage integrity and early erosions, involves no ionizing radiation, and provides excellent soft tissue contrast. A key clinical pearl, magnetic resonance imaging can detect juvenile idiopathic arthritis changes 6 to 12 months before they appear on plain X-rays. The coronal short tau inversion recovery sequence shown confirms bone marrow edema as bright signal and synovial inflammation in the hip joint, findings that would be completely missed on the normal plain radiograph obtained earlier. Case 9. A 6-year-old girl presents with persistent swelling of her left knee and right ankle for 10 weeks. She has no fever, rash, or systemic symptoms. Physical examination reveals warm, swollen joints with limited range of motion and morning stiffness lasting 45 minutes. Laboratory results show erythrocyte sedimentation rate 42 millimeters per hour, elevated. C-reactive protein 18 milligrams per liter, elevated. Antinuclear antibody positive at 1 to 320 with homogeneous pattern. rheumatoid factor negative, and anticyclic citrullonated peptide antibodies negative. Which complication requires the highest clinical vigilance in this patient? Option A, rheumatoid arthritis progression. Option B, chronic asymptomatic anterior uveitis. Option C, systemic lupus erythematosus. Option D, psoriatic skin manifestations. The correct answer is option B, chronic asymptomatic anterior uveitis. Antinuclear antibody-positive oligoarticular juvenile idiopathic arthritis carries the highest risk for chronic anterior uveitis, a silent inflammatory condition that can cause permanent vision loss without symptoms. Risk factors for juvenile idiopathic arthritis-associated uveitis include antinuclear antibody-positive oligoarticular juvenile idiopathic arthritis with a 20 to 25% risk, early age of onset below 6 years, which carries higher risk, female gender with a 3-to-1 ratio, and peak onset 2 to 4 years after arthritis diagnosis. Ophthalmologic screening schedule. High-risk patients who are antinuclear antibody-positive, oligoarticular, and under age 6 should be screened every 3 months. Moderate risk every 6 months, low risk annually. Early detection through regular ophthalmologic screening is essential for preserving sight, as this condition is often completely asymptomatic until vision-threatening complications have already developed. Case 10. A 5-year-old girl with oligoarticular juvenile idiopathic arthritis has persistent right knee swelling for 12 weeks despite adequate nonsteroidal anti-inflammatory drug therapy. She developed chronic anterior uveitis during ophthalmologic screening. Physical examination shows moderate joint effusion with limited range of motion. Laboratory tests reveal elevated erythrocyte sedimentation rate and C-reactive protein. Her parents are concerned about long-term joint damage. What is the most appropriate next step in management? Option A, intra-articular corticosteroid injection. Option B, weekly oral methotrexate. Option C, daily oral sulfasalazine. Option D, topical cyclosporin eye drops. The correct answer is option B, weekly oral methotrexate. Methotrexate is the gold standard first-line disease-modifying antirheumatic drug for juvenile idiopathic arthritis with persistent joint involvement or uveitis risk. It effectively reduces synovial inflammation, prevents joint damage, and decreases uveitis progression when initiated within 3 months of diagnosis. Dosing is 10 to 15 milligrams per meter squared weekly, with a maximum of 25 milligrams. The oral route is preferred, with subcutaneous administration if gastrointestinal intolerance occurs. Monitoring requires complete blood count and liver function tests every 4 to 6 weeks initially. Folic acid supplementation at 5 milligrams weekly is essential to reduce side effects. The American College of Rheumatology recommends starting methotrexate within 3 months for extended oligoarthritis or any uveitis risk factors. Intra-articular corticosteroid injection may be used adjunctively, but is not the primary disease-modifying therapy in this scenario. Case 11. A 12-year-old boy with polyarticular juvenile idiopathic arthritis has been on methotrexate 15 milligrams per meter squared weekly for 6 months. Despite good compliance, he continues to have active synovitis in 8 joints including both wrists and knees. His erythrocyte sedimentation rate remains elevated at 65 millimeters per hour and C-reactive protein is 28 milligrams per liter. Morning stiffness persists for 2 hours daily, significantly affecting school attendance and physical activities. Physical examination confirms bilateral wrist swelling with warmth, limited range of motion in both knees, and tender metacarpophalangeal joints bilaterally. What is the most appropriate next step in management? Option A, increase methotrexate to 20 milligrams per meter squared weekly. Option B, add sulfasalazine as combination disease-modifying antirheumatic drug therapy. Option C, initiate etanercept, a tumor necrosis factor inhibitor. Option D, switch to hydroxychloroquine monotherapy. The correct answer is option C, initiate etanercept, a tumor necrosis factor inhibitor. Etanercept is the first-line biologic therapy for polyarticular juvenile idiopathic arthritis that fails to respond to methotrexate. It shows superior efficacy in reducing joint inflammation and preventing structural damage in children with nonsystemic polyarthritis. Key clinical points. Subcutaneous injection given twice weekly at 0.4 milligrams per kilogram or once weekly. Can be combined with methotrexate for enhanced efficacy. Regular monitoring for infections and malignancy is required, and it is approved by the Food and Drug Administration for children aged 2 years and older with polyarticular juvenile idiopathic arthritis. Biologic therapies by subtype. Etanercept targeting tumor necrosis factor alpha, is used for polyarticular juvenile idiopathic arthritis. Adalimumab targeting tumor necrosis factor alpha is used for oligoarticular and polyarticular juvenile idiopathic arthritis. Tocilizumab targeting interleukin-6 and anakinra targeting interleukin-1 are used for systemic juvenile idiopathic arthritis. Clinical Pearl. Tumor necrosis factor inhibitors reduce radiographic progression by 70% when started within the first 2 years of disease onset. Case 12. A 9-year-old girl with systemic juvenile idiopathic arthritis presents with persistent daily spiking fevers reaching 39.5 degrees Celsius despite 4 weeks of nonsteroidal anti-inflammatory drugs and oral prednisolone. She continues to have an evanescent salmon-colored rash, hepatosplenomegaly, and bilateral knee arthritis. Laboratory results show elevated ferritin at 1,200 nanograms per milliliter, erythrocyte sedimentation rate 85 millimeters per hour, and C-reactive protein 45 milligrams per liter. What is the most effective initial biologic therapy for this patient? Option A, adalimumab, a tumor necrosis factor inhibitor. Option B, etanercept, a tumor necrosis factor inhibitor. Option C, anakinra, an interleukin-1 receptor antagonist. Option D, tocilizumab, an interleukin-6 receptor antagonist. The correct answer is option C, anakinra, an interleukin-1 receptor antagonist. Anakinra is the preferred first-line biologic for systemic juvenile idiopathic arthritis due to its targeted mechanism against innate immune dysregulation. It rapidly controls fever, evanescent rash, and systemic inflammation within days to weeks. Key mechanisms and features. It blocks interleukin-1 alpha and interleukin-1 beta at the receptor level, produces rapid fever resolution within 24 to 72 hours, prevents macrophage activation syndrome, is superior to tumor necrosis factor inhibitors in systemic juvenile idiopathic arthritis, and is given by daily subcutaneous injection. This is critical. Tumor necrosis factor inhibitors like etanercept and adalimumab are largely ineffective in systemic juvenile idiopathic arthritis because the disease is driven by innate immune overactivation, not adaptive T-cell or tumor necrosis factor alpha pathways. Clinical Pearl. Early interleukin-1 blockade reduces macrophage activation syndrome risk by up to 70% and improves long-term joint outcomes in systemic juvenile idiopathic arthritis. Case 13. A 14-year-old girl with polyarticular juvenile idiopathic arthritis diagnosed at age 7 presents for routine follow-up. Her height is at the 3rd percentile with a height z-score of -1.9, and she has not yet reached menarche. Her mother reports she was previously at the 50th percentile for height before diagnosis. She has been treated with methotrexate and periodic oral prednisolone courses over the past 5 years. Physical examination shows weight 35 kilograms at the 10th percentile, height 148 centimeters at the 3rd percentile, Tanner stage 2 breast development, active synovitis in bilateral wrists and knees, and Cushingoid features. What are the most likely contributing factors to her growth impairment? Option A, nutritional deficiency and malabsorption. Option B, growth hormone deficiency only. Option C, chronic inflammation and glucocorticoid therapy. Option D, delayed puberty and thyroid dysfunction. The correct answer is option C, chronic inflammation and glucocorticoid therapy. 2 dual mechanisms explain growth impairment in this patient. First, chronic inflammation suppresses growth hormone secretion and insulin-like growth factor 1 production. Inflammatory cytokines including interleukin-1, tumor necrosis factor alpha, and interleukin-6 increase catabolism and reduce anabolism at the growth plate. Second, glucocorticoids directly inhibit chondrocyte proliferation at growth plates and disrupt calcium metabolism and bone formation. The Cushingoid features on examination confirm significant steroid effect. Clinical insight. Growth velocity monitoring is essential in all children with juvenile idiopathic arthritis on long-term therapy. Catch-up growth is possible with effective disease control, steroid minimization, and early escalation to steroid-sparing biologics. This case highlights the importance of using the minimum effective steroid dose and transitioning to biologics to protect growth. Case 14. A 7-year-old boy with known systemic onset juvenile idiopathic arthritis presents to the emergency department with sudden onset of high fever, lethargy, and bleeding. He was previously stable on tocilizumab therapy. Physical examination reveals hepatosplenomegaly, petechial rash, and altered mental status. Laboratory results show hemoglobin 6.2 grams per deciliter, platelets 45,000 per microliter, neutrophils 800 per microliter, ferritin 8,500 nanograms per milliliter, fibrinogen 120 mg per deciliter, and aspartate aminotransferase 250 units per liter. What is the most likely diagnosis? Option A, septic shock secondary to immunosuppression. Option B, macrophage activation syndrome. Option C, drug-induced bone marrow suppression. Option D, acute leukemia with blast crisis. The correct answer is option B, macrophage activation syndrome. Macrophage activation syndrome is a life-threatening complication of systemic juvenile idiopathic arthritis occurring in up to 10% of cases. It represents uncontrolled activation of macrophages and T lymphocytes leading to a cytokine storm. The 2016 diagnostic criteria include ferritin greater than or equal to 684 nanograms per milliliter, platelets less than or equal to 181 times 10 to the 9th per liter, aspartate aminotransferase greater than 48 units per liter, triglycerides greater than 156 milligrams per deciliter, and fibrinogen less than or equal to 360 milligrams per deciliter. Key clinical features include persistent high fever above 38 degrees Celsius, hepatosplenomegaly, neurological symptoms including seizures and altered mental status, bleeding tendency, and shock with multi-organ failure. Urgent treatment, immediate high-dose steroids, cyclosporin, and supportive care are required. This is a medical emergency. Case 15. A 6-year-old girl with oligoarticular juvenile idiopathic arthritis diagnosed 2 years ago presents for routine ophthalmologic screening. She has no visual complaints and denies eye pain or redness. Her joint disease has been well controlled on methotrexate. Physical examination reveals visual acuity 20/25 in both eyes, normal external examination with no injection, slit lamp examination showing posterior synechiae in the right eye with anterior chamber cells 2+, and normal optic disc and macula bilaterally on fundoscopy. What is the most appropriate next management step? Option A, continue current ophthalmologic monitoring schedule. Option B, initiate topical corticosteroid drops immediately. Option C, refer urgently to pediatric uveitis specialist. Option D, discontinue methotrexate and start biologics. The correct answer is option C, refer urgently to pediatric uveitis specialist. Posterior synechiae represent iris to lens adhesions indicating chronic anterior uveitis with significant inflammation. This finding signals potential vision-threatening complications requiring specialized management. Important features of this complication: silent progression that is often asymptomatic until advanced, risk of secondary glaucoma and cataracts, requirement for immediate anti-inflammatory therapy, and the need for pediatric uveitis expertise for optimal outcomes. Simply continuing the monitoring schedule would be inadequate given active structural changes. Initiating topical steroids alone without specialist evaluation is insufficient for posterior synechiae. Discontinuing methotrexate would worsen both joint and eye disease. Emergency message: posterior synechiae indicate chronic inflammation that can rapidly progress to irreversible vision loss without specialist intervention. Same-day or next-day referral is the correct action. We would like to take a moment to invite you to join our Patreon community, Pediatric Case Review. Our community gives you access to a complete medical education library with all lectures organized by medical system, so you can find every topic you need instantly without searching through multiple playlists. You will also have access to comprehensive presentations with high-resolution clinical images, downloadable slide sets for offline study, practice multiple choice questions with detailed explanations, exclusive video recordings and case walkthroughs, and regular updates with new content every week. If you are ready to join and want to know how to subscribe, simply comment below on this post, and we will message you directly with all the subscription details. We have now reached the end of this comprehensive case-based lecture on juvenile idiopathic arthritis. Today we explored 15 cases covering clinical presentations across all juvenile idiopathic arthritis subtypes, pathophysiology and immune mechanisms, evidence-based diagnostic approaches, current treatment algorithms and biologics, and critical complications including uveitis and macrophage activation syndrome. Key take-home messages: oligoarticular juvenile idiopathic arthritis requires early ophthalmologic screening. Systemic juvenile idiopathic arthritis is autoinflammatory, not autoimmune, and responds to interleukin-1 blockade. Methotrexate should be initiated within 3 months of diagnosis for persistent disease. Tumor necrosis factor inhibitors are first-line biologics for polyarticular failure, and macrophage activation syndrome is a life-threatening emergency requiring immediate recognition. Next week, we will be covering pediatric inflammatory bowel disease. Please follow Pediatric Case Review for weekly evidence-based pediatric lectures covering all major systems and conditions. If you have clinical questions about juvenile idiopathic arthritis or other pediatric conditions, comment below and we will address them in future presentations.